one, because if you look at the audit your last 1,000 cases of transrectal, hardly nowadays you see infection, which has now gone to the stage of being anecdotal. However, this is a good biopsy. I myself would like to learn and reserve this for apical tumors. What is your comment on that? Rather than, appeal for a wholesale change and shift over from this gives, the general urologists, the radiologists and everybody to perform biopsies. That is more important because the largest section of biopsies, pathologies come out from whatever biopsies you do, whichever we do. But in difficult situations, yes, transperineal is correct.
I think that we shouldn't be debating that right now. I think that ship has sailed. Transperineal biopsy is definitely causes less infection than transrectal biopsy. I think that's been proven everywhere.
We move on.
Let's not go to that part of it. But I think in terms of what we're able to diagnose the cancer detection rate in the apical tumors, definitely better as well. Right?
Dr. Anand,
thank you.
I just want to say I've been doing this transperineal
Sir,
stepper and stabilizer template guided. What you say is it's only the mindset. See, your mindset also has to change, that you can reach places where you cannot reach without a template.
So may I interrupt you,
so
please?
That is the only request I would say.
Thank you.
We move on to the next speaker. Thank you so much, Dr. Ananthakrishnan Sivaraman. Our next speaker is Dr. Indranil Malik, and he is a senior consultant radiation oncologist at Tata Medical Center, Kolkata. He will be talking on Has the Sun Set for the CT MRI plus bone scan in the PSMA era? Current relevance of conventional imaging in MCS-PC.
Yeah, good morning and thank you everyone. I'm going to talk about whether conventional imaging has any relevance left at all in our clinical practice. But I'm also going to add a few words of caution on should we base on all our decisions on the PSMA PET. So we're going to discuss what are the advantages of PET-CT over conventional imaging. Can PSMA be used to make all the crucial decisions that we are making in prostate cancer right now? And what is the role left for conventional imaging? Now, this is particularly important for India because I think that there has been a major shift in abandoning conventional imaging and moving wholesale into PSMA PET-CT. We have to see whether we really want to do that in all settings or not. So what do we know about PSMA versus conventional imaging at diagnosis? We have the PRO-PSMA trial, which I'm sure pretty much all of you are aware of. And and what it showed is that in terms of sensitivity, in terms of specificity, there was a major advantage of using PSMA PET in the initial diagnosis. And that translated into benefit both for the detection of pelvic nodes as well as distant metastases, and led to a management change in as many as 41% of patients. Not only that, the equivocal findings reduced, and the management change when using PSMA PET as the second-line imaging, as a confirmatory imaging, was also very high. Now, this was a pragmatically designed trial in Australia, and using the best methods possible, they determined that this really was a big change in how we look at prostate cancer staging. Now, the question is that, do we need conventional imaging anymore? And by that, I mean a CT or a multiparametric MRI or, bone scans. Now, for the characterization of the primary tumor, there are actually no studies that clearly show a benefit of PSMA PET alone versus multiparametric MRI. So the anatomical detail that you will see on a multiparametric MRI simply does not exist in a PET. So in terms of T staging, if you're going to use that to decide whether you will operate or not, still rests very much on a multiparametric MRI. However, there is now emerging data that a PSMA PET MRI, if your hospital happens to purchase one, is likely to add some benefit in terms over multiparametric MRI alone, both in extraprostatic extension and seminal vesicle invasion. But till that happens, and I'm pretty sure it's going to take a long time, if at all, we have to still look at the multiparametric MRI. Can we use the PSMA PET CT to, not do pelvic nodal dissection, for example? Now, unfortunately, the studies and the meta-analysis shows that although it is a lot better than conventional imaging, the sensitivity is still in the range of 50%, which means that it's not good enough at the moment to abandon your pelvic nodal dissection based on the PSMA PET CT. And of course, when we look at the utility of an investigation like this would also depend on the prevalence of nodal risk stratification, or how many patients in your practice are node positive. So if you look at the last row of the table, in our practice, because we see mainly locoregionally advanced disease, closer to a 40% lymph node incidence risk, it's still, the negative predictive value is still not very high. So there is a 15% chance that a negative test is wrong. So you can't use it yet to decide your, the extent of your surgery, and similarly, the extent of your pelvic nodal fields if you're using one as a radiation oncologist. Now, however, can we ask the question in a different way? That if we are saying that the PSMA PET is there but not completely there, should we use that? Does that make a difference in our prognosis? Can we ignore a tiny PSMA avid lymph node in determining whether surgery should be done or not? And this study, which has been widely quoted, many reports have come out on using pre-surgical gallium PSMA PET, showed that it makes a marked difference in terms of post-surgical outcomes on whether the PSMA was positive or not. Therefore, it does matter. And incidentally, this is not the perfect graph to show. They showed that even if it was pathologically node negative, but PSMA positive, that still had a marked effect on your prognosis post-radical prostatectomy. So the use of a PSMA PET CT is going to change the risk distributions in a particular way. So there's going to be a stage migration that will affect, if we are using it as the gold standard in your practice, that's going to change the treatment in between 5 to 40% of patients. Now, what is that likely to result in? We are going to have lower risk localized patients, and the entire group is going to shift with ultimately a greater high volume metastatic disease. Now, what this is theoretically likely to result in is that every stage should have better outcomes, right? Which is known as the Will-Rogers phenomenon. Now, the question is that with all our clinical practice based on conventional imaging-based evidence, do we know that this actually happens? The answer to that question, as I mentioned, so everything, even in the metastatic setting, every single trial that we follow today is based on conventional imaging. It's not based on PSMA PET CT. So the results of those trials, whether the results or the benefits are going to get diluted by having lower risk patients in each strata, is a question that has not been answered yet. We do not know whether basing our treatment on PSMA is likely to result in better outcomes or not. Okay? However, very fortunately, there are randomized control trials going on, which are looking at this question. They have not started very long ago, so we will have to wait for a few years before this question is answered. And I have a sneaky feeling that by that time, no one is going to go back to conventional imaging, even if the trials do not show a positive result. But it's still very good that people are actually doing these studies. There is and we will see how that pans out. Until that time, I would not recommend that for a poor patient, you force them to do a PSMA PET-CT because we do not know whether it impacts outcomes or not. And of course, we know that there are pitfalls of using PSMA PET-CT as well. There are false positives, multiple ones. Every month, there are reports of some new entity that lights up on PSMA PET. Now, in the recurrence setting, things are slightly different. What is different is that PSMA PET-CT is just far, far superior to conventional imaging. Conventional imaging has only a detection rate of around 10 to 15% in the early recurrence setting, whereas the PSMA PET has close to 30 to 50% detection rate. So the comparative trials have been done, and they show clear superiority. Now, of course, we know that the detection rate will depend on what your initial PSA is. And in the post-radical prostatectomy setting, if you're trying to image with a PSMA PET at the less than 0.5 level, you're going to get less than a 50% detection rate. So should you be using it then to guide your clinical practice in that setting? Can we omit salvage radiotherapy in the post-prostatectomy PET negative patients? The answer is no. There was a study done which found that, in fact, the effect of radiotherapy was the best when you had a PSMA negative state in the early salvage setting.
So may I request you to please wind up in
Yes.
the next 30 seconds?
Yes, so non-metastatic castration-resistant prostate cancer is a setting where this is very useful. In fact, whether the entity exists at all or not is not clear anymore, because a study done with the same inclusion criteria as the trials in non-metastatic castration-resistant prostate cancer showed 98% patients had metastatic disease. So yes, there are prospective studies that show that treatment or salvage treatment based on PSMA PET does result in improved outcomes. So therefore, in this setting, there is a clearer case for using PSMA PET. So to summarize, at primary diagnosis for T staging, MP-MRI is still standard. For NNM staging, it's optimal to do PSMA PET, but you should not force people to do it because we don't know whether it leads to improved outcomes. Surgical decisions cannot be done only on the basis of PSMA PET. Radiation PSMA can help in targeting nodal and low volume metastatic disease. In the systemic treatment scenario, the benefit is still not that clear. In the recurrent setting, in the post-RP rising PSA, PSMA prognosticates but cannot be used to change treatment. Decisions on local therapy and PSMA targeted therapy, PSMA PET is much better than conventional imaging. And again, in decisions of systemic therapy, it can change the choice of agents available to you, but there's no evidence that it improves outcomes. Thank you.
We have just 4 minutes for questions, so 3
Indranil,
questions.
What I wanted to ask you is, this is the information that is available in the world literature. How to focus it from an Indian context? Keep in mind that we have more aggressive disease, low PSA secretors, and PSMA PET is available for a penny.
I think there's no question that PSMA PET is more accurate. So if PSMA PET is available at a reasonable cost, I think it just gives a more accurate diagnosis. However, there are situations where even a 10,000 rupee test is difficult for patients to do. And in there, we do not have enough evidence to force a PSMA PET. In the recurrent setting, only if you're planning specific PSMA-based local treatment, only then is the PSMA PET-CT clinically useful for patients.
In our practice, Dr. Ginil here, In our practice, we see a lot of patients coming with PSMA PET CT rather than MRI referred from outside, and sometimes they ask us whether we should repeat MRI for
Yes.
directing a
Yes.
biopsy, because personally I feel that PSMA is not specific in the prostate compared to the
Yes,
MRI. What is your opinion?
yeah, you're absolutely right. You must have an MRI if you're planning any kind of local treatment.
Dr. Sanjay Edla here. There is always this question between diagnostic capability and prognostic capability. We have demonstrated prognostic capability of a bone scan, like a patient who has got 5 lesions is worse off. Do we have similar things for PSMA?
In terms of being,
Prognostication.
yes, yes. In fact, there's emerging evidence that PSMA is a very important prognostic factor. Both the SUV, the volume on the PSMA. There's now a lot of publications that look at the volume of the PSMA, and it's showing excellent at every level, in fact, of even metastatic disease.
Dr. Indranil, thank you very much for this modern topic. Basically, Pro PSMA trial, it all came from Peter McCallum, Michael Hoffman, and Declan Murphy. So I have talked personally with them. Also, I have gone through their literature. All their message is very loud and clear that you should be very, very selective while using those theranostic tools or diagnostic tools, whatever you want to apply. So as a uro-oncologist or radiation oncologist, whatever we are practicing, we should have a priority. If your outcome is going to change, line of treatment is going to change, then we have to use those diagnostic tools or theranostic tools. Otherwise, those are very, very reserved ones. That was the person from Declan Murphy himself. So what is your opinion? Yeah.
Let me comment on that. If in India, like in the West, the PSMA PET was a lot more expensive than conventional imaging, I think there would be a strong case not to do PSMA PET, because we don't know whether it's going to change outcomes. And what has happened in India is that a PSMA PET is perhaps the same cost as a combined conventional imaging cost now. And that, by virtue of the fact that it is a more accurate test, we don't know whether we should, whether the same principles apply in choosing here in India. That's the situation at the moment.
In Australia,